Okay, hello, and welcome to Virtua's Health's Real Talk Women's Health Chat, one of my favorite things I get to do. I'm Nicole Michalik from 92.5 XTU. I just jumped off the radio, and now I get to be here talking about these incredible topics with incredible women and super smart doctors. And we're going to get into it tonight, but let's talk about a few helpful hints. Your camera and microphone are turned off, but you can still ask our panelists questions through the Q&A tab. You can choose to submit questions anonymously. A number of you have already submitted excellent questions for our experts when you registered, and we'll incorporate many of them into the discussion tonight. So just hang tight. And again, if we're not covering something, feel free to put it into the Q&A chat. So let's jump into it. I am so pleased to introduce our experts for tonight's session. Women's primary care physician, Dr. Meka, and Rowan vascular surgeon, Dr. Brotman. Thank you so much for joining us. You guys are amazing. Dr. Meka grew up in the suburbs of Philadelphia. She attended medical school at Philadelphia College of Osteopathic Medicine, right across the street from us here in Bala Cynwyd. We see them all the time on City Avenue. And she completed her training in South Jersey. She sees patients at Virtua Women's Primary Care in Morristown. In her spare time, she likes to travel and recently visited Amsterdam and Lisbon. I was in Amsterdam last year too. It was great. She loves trying new restaurants, cheering on the Super Bowl champs, Philadelphia Eagles, relaxing at home with her two orange cats, Mango and Tango. Oh my God, that's cute. I love that. So cute. Dr. Brotman is magna cum laude graduate from Harvard. I mean, come on, snaps. That's amazing. And she is currently the chair and associate professor of the Department of Surgery. She leads the surgical curriculum and loves to teach. She has special interests in venous diseases, including varicose veins, venous insufficiency, and advanced venous surgery. Dr. Brotman is a mom and a health enthusiast that enjoys early morning runs. We do not have that in common. You need to teach me how to do that, Dr. Brotman. She sees patients at Rowan Vascular Surgery, an affiliate of Virtua Medical Group in Stratford and Mount Laurel. Welcome, everyone. Thank you so much for being here. So today we're talking about all things varicose veins, what they are, risk factors, how to know if they might be indicative of something more serious. You know, this is so great because so many women think it's just a physical look, right? Like, my mom hates her varicose veins. Like, she talks about them all the time. And when I saw that this was our topic, I said, oh, this is going to be so great because there's so many questions about that. Number of great questions we had already received. It's such a relatable topic and there's a lot to cover. So we're just going to start with the basics. Dr. Meka, can you explain what varicose veins are?
Absolutely. I'd love to start off. So I would say that varicose veins are basically what we'd call visible dilations, generally greater than 3 millimeters in the lower veins of your legs. They can happen in any part of your body. These cause that typical look of like swollen, twisted, widened veins that can feel lumpy or bulge out and then can be cosmetically irritating, cause pain, itching, things like that. Some of the causes of that are going to be things like chronic venous disease, linked to venous hypertension, or basically high blood pressure in the veins. That can cause things that we're going to talk about today, like spider veins, varicose veins, other manifestations. And at the root of it is just basically leaky valves that cause reflux of the blood, and it makes it hard to get down to the legs. It's actually really common, as we were saying. That's why it's such a topic that resonates with many people. It's present in like 10 to 30% of the population, and higher rates amongst women, which makes this talk really fitting too. Higher with age, other populations as well.
So fascinating because I think a lot of women probably think that it's just cosmetic and it's not. So, Dr. Brotman, is there anything you want to add to that? And then also, if you could break down the difference between varicose veins and spider veins.
Sure. So first, I think there's a question from Phyllis: how bad should venous insufficiency be? So one is what is venous insufficiency? How, let me just break it down. Vascular surgery, there are tubes in your body. There's three. There's veins and arteries. And a lot of people come in with an not understanding of both. Arteries bring blood away from their heart and they deliver oxygen and nutrients to your body. the idea of veins is to bring blood back to your heart. And the way we do this is we walk. So unfortunately, our legs have to work against gravity, which is why you don't see varicose veins in your arms, because you can raise your arms above your heart and naturally drain the blood, right? So
This is why these sessions are so good. So it's like
yeah.
great
So
for like one goes one way, one goes the other way.
right.
Okay, this is great.
And so the way the blood gets back to your heart is basically you walk and the calf muscle passively pushes blood up, and there's one-way valves in your veins. And so they're supposed to shut so blood can't go back down. And the definition of venous insufficiency is these one-way valves remain open, blood pushes down in the wrong direction before it comes back up. And if it pushes down into the branches become dilated. And those dilated veins deform the skin, and that's what varicose veins are. So there are actually veins below the varicose veins that are the root cause. And that's what we treat when we treat the root problem of venous insufficiency. Okay. Because we can shrink the varicose veins by treating that branch.
Okay.
I'll try. Yeah.
So you said about calf muscles. If you have big calf muscles, is that a good thing?
All muscles are good. Working out is good. Yes.
When I have to try to get the knee-high boots over my calves, I'm like, maybe this is helping those varicose veins.
Yeah. So the answer is venous insufficiency in and of itself is not hard. It's not it's not like your appendix or a blockage in your heart, but it can cause pain and discomfort. And so when I say, should venous insufficiency be treated? Yes, if it causes symptoms. It's symptom based. So if someone has a lot of what we call reflux, the blood is going in the wrong direction for a long period of time, and I consider severe 2 seconds. You allow your body up to half a second for it to go in the wrong direction. And so, but the time doesn't really matter. I have people who come in with large varicose veins and said, my doctor said I should come and see you. And I said, well, does it bother you? No, I lived with it for 70 years. I'm like, good, that's fine. No pain. We don't have to fix it. There are other people who have significant itching and pain. And when they stand for a long period of time, their leg aches and it's heavy, and, they have trouble exercising, or they have restless leg. All reasons to treat. Is it dangerous in and of itself? The veins that are connected to the varicose veins are what we call superficial veins. So getting clots in them, while very painful, generally, I'll say generally, do not cause the blood clots that go to your lung. Those are a different set of veins.
Got it. That's good to know. So really quick, let's backtrack for 1 minute. The difference between varicose veins and spider veins.
Okay. So the difference between varicose veins and spider veins are broken down by size. In general, varicose veins, as Dr. Meka pointed out, are greater than 3 millimeters. And varicose veins in and of themselves, by definition, deform the skin. They're what you bulge.
Bulge. Okay, yep.
They bulge. In between varicose veins and spider veins are what we call reticular veins. They're not spider veins. They're not varicose veins. They're somewhat in between, like 4 millimeters, and they're dark blue, and you see them on, they're not the red little spider veins. There's something else beyond that. If you ever go to the beach and you see those people with like a lot of blue veins around their ankle, that's called corona phlebitis. That's a risk for ulcer, and that should be treated. And then spider veins are those really red, fine veins. And the criteria, and this is important, the new 2023 guidelines published by the Society of Vascular Surgery say spider veins are strictly cosmetic and don't even need an ultrasound to be worked up, because it causes an overuse of procedures on people. And if we all read the New York Times, we know that people doing these procedures shouldn't be doing these procedures. The only people that should be doing these procedures are board certified vascular surgeons, not interventional radiologists, not cardiologists, not general surgeons, not family practice. The surgeons that are trained to do this are vascular surgeons. Yeah. And the New York Times, if you follow them, have shown how much fraud there is, because we can probably get any person to stand and get half a second of reflux and say, oh, we should treat your vein. And the centers do this all the time. So you want someone that really understands what's going on, traces the varicose veins back, finds the refluxing veins, and appropriately treats you.
Yeah.
So spider veins are cosmetic. They can cause pain and they can have underlying reflux only in specific cases.
So, Dr. Meka, obviously you're a primary care physician, so people will come to you first, right? So you're seeing them. Talk a little bit about what that process is like. If somebody comes to you and says, "Oh, my leg bothers me," are you talking about common risk factors and then prevention? And then when would you send them to Dr. Brotman?
Yeah, so a lot of the risk factors that are associated with varicose veins are also things that I can definitely help with. Some of the things that you would think about are actually being a woman. Estrogen makes your valves a little bit more leaky.
Another the fact all
Yeah,
women go through. It's the we do these health chats and then I leave with rage because I'm like, another thing. Why is that? Is it because of estrogen? Is that why women are more prevalent to varicose veins than men?
actually, I believe that it is just the estrogen. Yeah, women that have had more children too are actually at a higher risk. Other things to think about are, advancing age, prolonged sitting and standing, which Dr. Brotman explained with gravity, and increased body mass index or obesity, which I deal with quite a lot, and prevention techniques, things like that. A pregnancy state, unfortunately. Um, Smoking, which I also am obviously always able to help with and counsel on. And then rarely like lower extremity trauma, things like that. So I think regarding if they're genetic or not, in a sense they are. I think I just read that when both parents are affected, there's like a 90% chance of developing it. But then you also have to think that a lot of the things I just talked about are also, in a sense, genetic. So where I would come in is I would think I would help you reverse those factors that I can as a primary care doctor. So absolutely smoking cessation, weight management, counseling there, pregnancy. Once that result, like certain things resolve, then hopefully the veins themselves also improve. When that isn't able to be done, then I would absolutely refer to vascular and Dr. Brotman. We're going to go into more ways to manage going forward, but basically like wearing comfortable orthotic shoes, like I said, smoking cessation and focusing on like a heart healthy diet and making sure to remain active throughout like the whole day and at all points of life, ideally. Trying to move at least 5 minutes on the hour, something like that is where I would start. And compression stockings and elevating the legs above heart level. And like Dr. Brotman said, if they're still having discomfort after all of that, then I would happily refer to vascular.
So, Dr. Brotman, varicose veins, you said spider veins are cosmetic, but varicose veins can be a sign of a broader health issue. And when they come to you, are you immediately doing surgery or do you try other things at first before that you do the surgery?
So one is the 2023 guidelines from the Society of Vascular Surgery sort of changed the way we treat varicose veins. They say, you know what, forget compression socks because we know no one wears them. They're good for your legs, but like really anyone going to wear them? Just go and get them treated, right? So I will say this, that if you have spider veins or if you have varicose veins and you have complaints of pain, I'll treat you the same way. The way we start, we don't just jump to surgery because you treat the patient. So if someone has pain and has spider veins, I'll treat them as if they might have an underlying vein problem. More often than not, those spider veins are just cosmetic, but it doesn't mean we don't treat them the same way. So it's really important to really listen to the patient if someone comes in and complains of pain. So really the first thing that we do is we define what's going on. What's happening to your leg, right? So I look at you, I look at your legs, I stand you because it's much different standing than not standing. And, right. And then we ultrasound you. And the proper way, okay. Yes. So the first is because I can't see what's going on beneath the spider veins or varicose veins. So the way to determine what's going on is an ultrasound. That ultrasound should be done standing. You won't get the same result lying down. So that ultrasound, if done lying down, will not give you appropriate results, which
Because
is why I
gravity.
often have to
Right.
repeat the ultrasound because they tell me that they were lying down when that ultrasound was done, and that's not the appropriate way. So
And
I check for any blood clots, and then I stand you, and we ultrasound the leg, and we check the if the blood is going in the wrong direction. If it is,
so
and
that's what the ultrasound is for, to check where the blood is going.
to check if the blood is actually refluxing, going in the wrong direction, are coming from. Because generally speaking, there's a branch, a straight branch, a named straight branch in the leg that isn't working appropriately that can be shut down in a minimally invasive way in the office. And no, I don't just jump to surgery because also, we want to approve it by insurance and we want to make sure that it is. And then they do come for there's a whole plan, we can't just remove the varicose veins. We shut the feeding vein down first, hope the varicose veins shrink. Veins are muscles, right? So if they have
Oh,
right. So a
I
lot
didn't
of
know.
times they have muscle memory. So if they don't shrink back down and they've been dilated for a long time, we then set up a procedure to remove the varicose veins.
Yeah.
Yeah.
Wait, back to compression socks really quick. It feels like it's a hot topic. Like I see it all over TikTok. Are they like, oh, varicose, I mean, compression, they talk about like how they help if like you're going to, like, a lot of people were wearing them during like the Eras tour for Taylor Swift because it's like a 3.5 hour show. And then people talk about like the compression booties that everybody sees.
Yeah.
Like, I think a lot of people don't, but do they help with this with veins, or is it just for like swelling? I mean, I guess swelling and veins are kind of like the same, they're all connected.
So here's the deal. 2023 said, if you have a varicose vein problem, like, let's get real. It's not getting better with compression socks. You're not going to make it go away.
Yeah.
Once you have varicose veins, compression socks are not making your vein problem go away.
Okay. Okay. Yeah.
They do help with venous return. So if you're on your feet for the Eras tour for 3 hours, they are helping you walk, right? They're
Right.
compressing the blood to go back up. So they're comfortable and they're helping with venous health. They
Okay.
might help a little bit with prevention, but they're not going to stop the process going on. So if I'm in the OR for a very long period of time, it's nice to wear. Your legs will feel better. But also
Mhm.
there's a compliance issue because I always oversize. I'll measure specifically for my patient. I stock them myself because I oversize them. No one can get on an appropriate size compression stock and be compliant with it. So I
Okay.
oversize. I make sure that they can wear it.
Yeah, because I'm always so curious. I feel like it's such like a hot item now. People are talking about. I'm like, what am I missing with
and
this?
you can get them in hot pink. So
Yeah. So there we go. So, Dr. Meka, is there anything topical that you would give your patients before you would send them to a vascular surgeon? Like, is there anything that like topical creams or a massage? I mean, I think it's probably in the same vein, no pun intended, as compression socks, that it's probably like I'm assuming topical creams won't necessarily cure it, but could they help like put it at bay? Like, are you
Yeah.
prescribing anything before they would go see Dr. Brotman?
Yeah, I mean, it depends also on what their schedule is and when they're able to get in. So until they're seen, absolutely. And I think Phyllis is saying that she does wear her stockings up to the knee. And I do, I mean, I wore mine on my surgery rotation and it definitely helped with like getting the blood flow going.
Mhm.
And it definitely sometimes like feels better until you can get in and get seen. Topical things I would recommend are probably like calamine lotion and topical steroid to prevent the itching and antihistamine, things like that, because we just want to keep you from itching and prevent like any infection from being introduced to the area. And then seeing vascular after that. Yeah.
Interesting. Okay, so Dr. Brotman, we received questions regarding surgical and non-surgical treatments. So can you take us through those? So there's minimally invasive treatments, like laser treatments, radio frequency, and then there's actual surgery. So can you maybe break down a little of those? I guess it has to do with the degree of how severe your issues are, right?
I'll break it down just a second. And there the United States is really poor for in terms of like nutrition and FDA approved studies for what are they called, alternative medicines.
Yeah.
There have been some studies proving that like horse chestnut extract can help with the spider veins and some of the pain. There's orange rind extract. There's some off-label uses that might help with pain. Nothing that's going to get rid of varicose veins. Maybe
Right.
help lighten the spider veins. Okay, so to get to the topic of how do we fix this, the way to fix this is through a procedure. I don't really call, you can call them surgery, you can call them procedures, they're all the same. I'll go through them. So there are procedures to fix, remember that trunk vein that connects to the varicose vein. That's what we shut down first because it connects, it pushes blood into the varicose veins. And there's 5 FDA approved ways to do this. They are all minimally invasive. They're all done in the office. Whether or not you call it a procedure, it's up to you, but we have to enter the vein to do it no matter what. So
Right.
2 of those are what we call heat based. And this is where a lot of people get laser confused because when you think about a laser, you think about like removing dark spots on your face, right? But this is inside a
Or
vein using
laser
a
hair
laser.
removal. Like,
Yeah, laser hair removal.
yeah.
Hmm.
Because that technically like gets to the root, right? So I
Yeah,
get how people would think it's the same, but this is
right.
like veins. Like we're talking
This
about
is
like
a laser inside of your vein. So I under
Hmm.
ultrasound, I access the vein and I put a catheter in. One of them is radio frequency type of catheter, one is laser based. They both do the same thing. They heat the vein shut. So I numb around the vein by injecting the same thing we do for liposuction. It's called tumescence. It's a bag of anesthesia that's injected into your leg. Same thing that you would use for liposuction. And then I heat it shut. There's another method that's more recent called cyanoacrylate glue. It's basically a catheter that delivers glue inside the vein that shuts the vein down. That's called VenaSeal. Okay. The other ones are, venous closure or, some type of laser closure.
yeah.
The other is also a a way to close it. It's called Varithena. It delivers basically a detergent like substance into the vein. It irritates the lining of the vein and then by compression shuts the vein down. And the last is a pharmacomechanical, meaning we inject medicine and irritate the lining of the vein to basically destroy the vein. And those are all done by a catheter. Under ultrasound, I put a catheter inside the vein, and then I basically pull the catheter back, and I'm either heating it or medicine based, shutting the vein down. Once that is done, yes. So that's all done in the office. It's about half an hour, 40-minute procedure. And then
Like
you're walking out. You can drive home. You could do whatever you want.
every day I'm like science man, like,
Yeah, it's getting better. I
it's
mean,
getting, yeah.
science is trying to fix the valves right now, but no one's been successful. If you can, you'll make $1 billion. But
Yeah.
Hmm.
I
the
have a very remedial question, but like we have multiple veins, I guess. So when you seal off this one vein, you have other veins that could still carry the blood and the oxygen, right?
good question. So again, our body is very well made. There are 2 sets of veins in our body. There's a deep set,
Okay.
and this is where you hear of deep vein thrombus, and that's where it goes to the pulmonary embolus. You've been sitting on the plane for a long period of time. This is where compression stocks are very, very useful because they prevent DVTs. If you're on a plane for a long period of time, you should be wearing your compression stocks. It's not going to prevent, or treat varicose veins, but it will prevent deep vein thrombosis. Very important. It could save a life, right? If you're on a long plane trip.
Hmm.
And so the surgically, we only enter the deep veins if there's a major problem and your limb is threatened. And it's very, very different than the veins we treat for varicose veins.
Got it.
The
Okay.
veins we treat for varicose veins are superficial and expendable. We don't need them. They empty and dump into the deep veins, which we do need. So, yeah, we can manipulate the superficial or the veins closer to your skin system without compromising the blood flow back to the heart
It
or
is
your
crazy
leg.
when
Yeah.
you think
So
about
that's
it.
the answer. Yeah.
I know. It's like, oh my goodness. So we talked a little about in the beginning about the causes for varicose veins, right? And you basically said it could, I think Dr. Meki, you talked about it early on, where it could be anything from smoking, genetics. Is there anything that could it just happen? You said pregnancy, could it just happen, or is there always a cause? I feel like in medicine sometimes there just isn't, right? Or we just don't know it yet.
Yeah, varicose veins, there's no cause. You scientifically, we can't prove a cause. There's causal factors, meaning we can relate something that happened or something that you have to having varicose veins, but there is no scientific literature that says this is the cause of varicose vein. We know it runs in families. We know women have it more often than men. We know that trauma can is a causal factor, but we can't say with definity what causes these. We just can relate them to causal factors.
Right,
Hmm.
makes sense. Yeah. My dad had Parkinson's and he went to Penn and his neurologist would say like we study this every day and sometimes we just like don't have an
Hmm.
answer yet. Somebody eventually science, right? Somebody eventually will know the answer to all these things and they'll
Yeah.
be really rich and hopefully we get to do another another seminar on it, right? It's so interesting. So we have a question regarding the efficiency of ablation specifically. Can you elaborate on that? Like, and we have all this information, we're examining our legs, like, what should we do? Well, let's just talk about the ablation first, and then Dr. Meka, because I think they would go to you as a primary care physician first to ask you about that. But Dr. Brotman, do you want to talk about the ablation part of it? And then
Yeah.
Dr. Meka will talk
The
about
so one is there was a trial called the recovery trial, and it basically says that the efficacy of both laser ablation and radio frequency ablation are the same in that there's a 97% effective rate over 5 years. So over 5 years, those people that get treated are 97% effective even at that 5 year mark. In terms of what's better, there's slightly more bruising with the laser versus the radio frequency and slightly more ecchymosis found, but they both can do the same thing. So that's the answer to that.
Yeah. So what would be concerning to you, Dr. Meka, when they come to see you first? What is something, or if they haven't made an appointment with their primary care physician, like when should they make an appointment with you first? And then, like I said, you would obviously send them to Dr. Brotman, but like if somebody's just at home examining themselves, they have this information, at what point should they call their doctor to be like, hey, I need you to look at these?
Yeah. I don't think there's any point that could be, too soon, really. Especially like Dr. Brotman is saying, especially if they're causing discomfort. But I think we even have a question that, cosmetically, if it's bothering you, I definitely want to help. So I think reaching out whenever you feel like it's something that you're concerned about and then getting in sooner than later so we can get that ball rolling and get the process started, finding you a vascular surgeon in the area, and the appropriate, follow up. And then we can also work on some of those things that we talked about, like, before, with moving, compression stockings, your diet, things like that. Anything that I can do to also help facilitate that. So I think sooner than later for sure.
Yeah, no, that makes sense. I mean, why not, right? There's never it's
Hmm.
never too late. So, Dr. Brotman, can you walk through what someone would expect during their first appointment?
Hi, nice to meet you. No, so when they come in, we basically talk to you and find out, what's going on, what's bothering you. Obviously, most people don't like the way they look, and it's a remedy as well when we. That's the good thing. When we fix the problem, also the cosmetics get treated. It goes hand in hand. And so, really, we're there to do a complete, full physical exam because there are also conditions in which you have to be careful. There are people that come in with very, very large varicose veins, and history taking is the most important thing. History and physical is the basic component of medicine, and do no harm is our Hippocratic oath that we have to follow, and it's very important to do so. So I can have to be careful in my mind, this patient has huge varicose veins, very painful, but yet you take their history and they had a history of deep vein thrombosis, and those veins are all clotted off. So they're living off their varicose veins. And of course, they're huge because they're doing overtime work, and shutting them down would risk limb loss. So it,
Ooh,
yeah, so
everything is
it
connected,
can't
right?
just
Yeah.
be let's just shut the vein down. It has to be let's discuss this with the entire patient, find out what's going on. If it's a simple varicose vein, fine. But the first component is taking a proper history, knowing everything about it, especially someone with a youth who has a problem, and maybe they have a limb length discrepancy, and they might have something called clipal trinane. Again, they are working only on their superficial vein because they have a diminutive deep system, and if you shut that vein down, you risk limb loss. But yet they have problems with their superficial system. So again, the very first thing, and a simple varicose vein is easy to take care of, and we do it every day, all the time. But history is first, and then a physical exam. I carefully look at the varicose veins and trace them back to the root cause, because a lot of times varicose veins in the posterior thigh in a woman, they come from the pelvis. They don't come from the leg. So an ovarian vein varicosity is the root cause, and shutting anything down on the leg is not going to help the varicose veins at the hamstring level. And these people complain of painful sex and heavy periods, and it's a very different complaint, but they still have leg pain. The root cause is not in the leg. So, you have to look sometimes below the iceberg to see what's going on underneath, and keep that in your brain at all times. And then we get to the physical exam and the ultrasound, and we find out what it is that we can treat. And that's the easy part. Once we get through the physical, once we get through what's bothering you, and then we trace the vein and we come up with a proper plan. What vein is leading to your varicose vein? Shut it down. And then we can talk about taking out the varicose veins in the office, which very, very small micro incisions, or injecting them as well. Everything's done in the office. And then injecting the spider veins. We come up with a comprehensive plan for each patient individually.
Yeah, that's the fact when you're talking about the pelvis, we did a really great seminar with pelvic floor and pelvic doctor, and there's so much again, back to the women, right? Like, there's so much that happens that we don't even realize. I have a quick question. Is there anything Dr. Meka, you mentioned estrogen in regards to this. Could veins be worse during your period or during menopause? Like, do you ever see that with patients, or that doesn't factor in?
So, like we mentioned before, a higher estrogen state is more of what we're concerned about. So definitely, with pregnancy, I do have a lot of patients that get varicose veins because the estrogen is causing dilation of your veins and overall increased blood flow capacity. You're carrying a lot of extra fluid. So that's definitely one state where we see definite varicose veins. Menopause itself, not quite, although, you're losing estrogen, but at the same time, it's also part of, unfortunately, getting older. So that's a different, risk factor that could play in. And I haven't seen exactly during your period. I don't know if Dr. Brotman has, but especially since that seems to be, a quick change in your hormones. I haven't heard of that or seen that yet, but, nothing would surprise me.
And really quick, I just want to make sure we talked about prevention, and you did talk about, is there anything you can do for prevention of varicose veins? Or is it just one of those things like, sucks to be you? I mean, I guess we did mention the smoking, obviously. We talked about exercise, standing up every 5 minutes, BMI and weight. Is there anything else that we may have missed?
I can't think of anything specific other than that, but I do think it just falls in a big umbrella. Anyone who sees me in the office knows that we do focus on like a healthy diet, cutting down smoking, and a lot of grains, vegetables, things like that. Other things to prevent, or at least prevent it from progressing would be those compression stockings, elevating above heart level, making sure that you walk. Like Dr. Brotman said, calf muscles are the biggest part of what we want to strengthen. So 30 minutes of activity a day, whether it's walking, stationary bike, elliptical, anything of that nature, some yoga to mix it up. Those would definitely be like a good point for starting with prevention. Those are all things that we can discuss in the office and help you along with from our perspective. Yeah.
My trainer had me do calf exercises the other day, and I was like, I don't need bigger.
Oh.
Now I got to tell them, well, smart doctor said I need to strengthen my calf muscles.
All of our muscles. Yeah. As women, we need to strengthen all of our muscles. But yeah, some leg lifts, things like that are definitely not going to hurt.
Perfect. Okay, so let's get to some of the Q&A. Dr. Brotman, I'm currently scheduled for a vein ablation. I've had all the testing, no salt and exercise. What causes the pressure, the tightness in the lower leg? It feels like someone is twisting them in a vice.
Um, so again, it's hard. This is like, I'll just compare it to someone who comes in my office with leg swelling and they're like, Doc, my legs are swollen. And so I'm like, okay, there are 100 million reasons why your legs could be swollen. And so when someone, literally 100, it could be your kidney, it could be your lung, it could be your liver, it could be, a problem with your
Mhm.
vein, it could be some mass compressing your iliac vein, it could be anything. And so when someone says my leg feels like it's being compressed by a vice, that's 100 million jumps to say it's your vein. And I can't make any conclusion with someone giving me a description of what's going on without a complete history and physical. So
Yeah. Well,
um
she's scheduled for a vein ablation.
yeah, so she's scheduled for a vein procedure. That doesn't
Yeah.
mean that the vice is it very just because she's scheduled for a vein procedure doesn't mean that that vice cause that symptom is going to be alleviated by an ablation just because they found reflux.
Mhm.
It's most of the symptoms from varicose veins are gradual and they happen over a long period of time, and it's been forever and they know it. And so if this is something recent, then I would be very hesitant to say my leg in a vice is from my veins. And so
Mhm.
it could be, but there's 100 million reasons why it couldn't. And so I take it on when I see a patient. There's 100 million reasons why it couldn't. Let's prove it's your veins. Because more likely than not, if that's the complaint, it's not your veins. And I'm very careful to say that because we all have read the New York Times and what's going on with medicine, and it is very scary what's happening. And people believe, people believe what they're told, and so just be careful. That's all I have to say.
So let's go for cosmetic. I don't like the look of my spider veins. What are some options to treat them? I think we talked a little bit about this, but is it just, lasers and surgery, or is there anything topical that people can do to help that? Because it seems that's more of like a cosmetic issue that people don't like the look of it. Is it like just get self tanner?
No, there's two FDA approved drugs for spider vein: sodium tetradecyl sulfate and polydocanol. We used to use saline, but we've created FDA approved drugs right now. They're basically detergents. They go into the spider veins. We're injecting them into the spider veins, and then we compress your leg because they irritate the lining of the leg, and then we compress them, and then they shut down. So a few things, risk factors. If you inject it too quickly or too forcefully, you can end up with an ulcer. So you really have to have someone who knows what they're doing. If you inject too
Mhm.
high a concentration, you can brown the skin and have a bad aesthetic result. I've done this everywhere. I inject, people come in later in life with like a periorbital vein or a vein on their forehead. You can inject those as well. You have to be careful because you can get blindness. So it has to be done the right way. We don't want to risk that. But yes, those are the FDA approved drugs. The really fine pink veins, they can be lasered. And that's the skin laser. So that's in addition to injection, what we call sclerotherapy.
Okay, awesome. So why do they disappear when I rub them and then reappear when I stand up? Does rubbing them cause harm? Have you ever seen this, Dr. Mika, where like people come into your office, or either of you can jump on that? I just was thinking about somebody that goes to their primary care physician and they're like, look, it went away.
The reason that happens when you inject sclerotherapy, they think their veins are being shut down because you actually see the blood being pushed out of them. It's a very similar phenomenon. When you push on your leg, you're pushing the blood away. So
Mhm.
you're extracting the blood out of the vein, and then it's going to come back. So you're basically pushing blood out of the vein.
Okay. Here's another question. I am being awakened during the night by pains in my legs that goes away when I get out of bed and when I put weight on them. It's not a sharp pain, more like an ache. Any idea what can be causing this? I mean, I feel like we talked about this. Like it could be 100 things. Like I would make an appointment with your primary care physician, right, Dr. Mika? If it is vein related, then you would send them.
Yeah, like I know it's like the whole theme of tonight is veins, but that's, definitely just one part of this picture. And without seeing you, it's really hard to tell. Although I do, like, a lot of people message me like this all day. But what I always say is, please make an appointment because the best tool we have is a history and physical. could be like a number of things, plantar fasciitis, restless legs. It could actually be your arteries and not your
Yeah,
veins.
it could be our, yeah.
It could, yeah. So, with the sentence, it's really hard to go off of, but in this, I'm kind of suspecting that it might be something not vein related. Yeah. So definitely come in and see someone for sure.
Dr. Brotman, will spider veins and varicose veins cause night foot cramps? And what are the effects of neuropathy with spider veins and varicose veins?
This is what the vascular surgeon teases out every day. Um, pain at night is very concerning for arterial disease. Quite honestly, restless leg is more veins, like that last question. If you have
Mm-hmm.
pain that you're waking up with and you have to dangle your foot over the bed, you're using gravity to get oxygen to your foot. But again, it is it's just like Dr. Meka said, it is too hard to determine without appropriate history and physical exam. In terms of neuropathy, neuropathy is more concerning with arterial disease because neuropathy is pretty prevalent in the diabetic. And that those people are for both venous and arterial are set up for ulcers and wounds, which are harder to heal in people with diabetic
And
neuropathy.
neuropathy is numbness and tingling,
Yeah.
correct? Yeah,
Mm-hmm.
Mm-hmm.
yeah. And so
And then
that,
Dr. Meka, I'm sure, sees that every day.
Yeah, it's really painful for
Yeah.
sure. Yeah, and anything that can predispose you to like, getting neuropathy is something that we want to help you treat and get taken care of a little bit sooner than later for sure.
okay. Mid-30s female, can anything be done with a raised vein over the ankle bone? Is it concerning?
Well, sure, we can remove it, but the appropriate with a 37 healthy-year-old, the vein that you don't like over the ankle, generally I can take out unless there's an underlying venous problem.
Okay, good to know. Sometimes I will get a quick burning pain in my tree vein area. It feels like someone
Oh
touched
my,
me
what
with a hot match. What's a tree vein area?
tree vein?
Yeah.
Hmm, I'm not
A
sure.
tree vein?
Yeah, that's what she said.
Oh,
She said, sometimes I get a quick burning pain in my tree vein area.
I don't know.
hmm.
Yeah, maybe she meant something else. I don't know. Um, okay, oh, what if you're on a blood thinner? How does that affect varicose veins and spider veins?
A blood thinner, it doesn't affect their progression. It just affects when we treat them. A lot of times, if someone is on a blood thinner, I do the procedure on a blood thinner. I'm not scared to do it on it. If I'll just do it because we're heating the vein shut. You are at a bigger risk of bleeding and bruising, but it can be done. If I'm making incisions and removing varicose veins, I like to stop the blood thinner if at all possible, for a few days before, a few days after. Reasons not to proceed with an elective vein procedure, or probably any elective procedure, is someone who's had a recent heart stent, things along those lines that are on blood thinners, because those you can't remove or your stent shuts down.
Oh, okay. I was
Mm.
told years ago after I had severe sunburn on my legs that my valves were not working properly. I do not have noticeable varicose veins. I do wear moderate compression knee high with no pain. Should I see a vein doctor for an opinion? I'm 84. First of all, the fact that you're 84 on a webinar, shout out to you. Knowing this is why 80 is the new 60.
20.
80 is the new 62. There you go. So she doesn't, you can't see it, but she was told that she has that. Um, is that something that she should get more of a specific opinion on?
I guess you could always, but if you're moving around, you're not having pain, veins is elective, it's not bothering you. From a strictly venous standpoint, it doesn't necessarily have to be checked out. I think that it's coincidental that there was a sunburn and then she found out there was a valve. My question is was the valve itself a venous valve or was it a heart valve? Like, I don't know. There's other valves in your body as well. From a venous
Mhm.
standpoint, if you're not having pain in your legs, even if you have some varicose veins in and of itself, it's not doesn't it's elective to be treated, but was that valve something else like a heart valve? I don't know.
Right. Dr. Meka, we talked really quick in the beginning about dark colored ankles. So like if somebody comes in and says they have dark colored ankles, is it immediately a vein thing that you're looking at a patient? Like, are you saying go to a vascular doctor right away, or could it be other things?
So again, it depends. When I'm thinking dark colored ankles, I'm thinking of a number of things, you know. I guess it depends if it goes along with those risk factors and if they're having, more of those itching, burning symptoms, and if they're having some of the other things that we spoke about, those bulging veins, and the larger ones in general. So once I looked at it, and if it did seem more like the vein nature, then I would definitely send to vascular. If it seems like it could be a derm issue, because some people, do get sunburns or do get rashes around lots of different areas, then I would focus somewhere else. But with veins, you do get concerned about venous ulcers and things like that. So I would not hesitate to send to vascular with that for sure.
Got it. Dr. Brotman, it said, I had the varicose vein procedure, but I did not go back to have the veins removed. The calf vein still swells. Should I be concerned?
Should you be concerned? If it's concerning to you and there's pain and you don't like how it looks, you can get it treated. I'm not concerned specifically in terms of like limb threat or life-threatening problem due to a varicose vein in the calf.
Interesting. Okay. So it basically is if
But
you're, yeah.
if it bothers you, you can get it treated. It's something easy. The question is, did it shrink after the ablation procedure? I'm not sure. And was that vein connected to the calf vein? I don't know.
Mhm.
This is interesting too. How bad should venous, am I saying that right? Venous insufficiency be
Venus?
before oh, it is venous insufficiency be before you consider surgery? But that should be a surgeon question, right? Or a
Um,
surgeon. Yeah.
no, the Society of Vascular Surgery does actually give out guidelines. By
Oh, okay.
definition, venous insufficiency is defined as something greater than half a second. I personally don't consider it severe until it's greater than 2 seconds. Everything in between greater than half a second and 2 seconds is a gray area. And this is where, again, we have to be careful because a half a second is normal. So if someone has zero point 0.6 seconds. Is that normal or not normal? In my opinion, it's kind of normal. But the insurance company will say, okay, you could do it, or we can push it through. Whether or not it will help you, I'll leave that you to be the judge on whether we should be treating 0.6 seconds. But 2 seconds is something severe that I would definitely consider treating. Between the 0.5 and the 2, 1.5, I
Mhm.
probably would treat. So that's your answer.
And I think
Mhm.
we talked about it when we first started, why we love doing these webinars. And Dr. Meka, you mentioned it at some point where you're saying like, and I think we talk about this a lot, like you have to be your own advocate and it's never too early to call your primary doctor, right? Like it's never too early.
Mm-mm.
And I think a lot of people wait too long, right? And you have these brilliant, brilliant doctors like you two
Mhm.
that we're so grateful to have. And thank you for sharing your expertise as we're about to wrap up. But I think that that's one of the main things that I always take away from these incredible sessions is that it's never too early to call your primary doctor if you're concerned. Don't wait too long because you want to be able to, nip it in the bud, no pun intended, as we get started. Before we wrap up and I give all your info, is there one thing, Dr. Meka and Dr. Brotman, that you would like to tell our webinar viewers and um, anything that we may have missed that you think that is important for them to know?
I mean, I'm reachable by email. If you go under the Virtua search button on the link at the page, you could probably just type in my name and I'll come up. I'm
Okay.
always happy to answer
And
questions outside of
I'm
this.
gonna give your info, and then at the end, everybody's gonna be emailed all the info so they'll have it. Um, Dr. Meka, anything that you think that they should know about care and you know being preventative or being on top of anything?
Yeah, I mean, if you're like, whatever your goals are and where you're feeling at, I'm happy to meet you there. And that's the thing I do like about Virtua is like even when I do refer to vascular, I get all the notes, I see the management, and I still feel like I'm, part of the plan. So yeah, just being really open and honest. And I've had I'll finish a visit and almost at the end they're like, oh, by the way, and I have like varicose veins, and it's like almost, like a little spurt at the end. And it's like,
Yeah.
don't hesitate to like, yeah, include that as like, that can be your whole visit. And it is like an indicator of other aspects of your health. So we'll be working on like, you know, your diet or your diabetes. And at the end, they'll mention that. So I would just say don't hesitate to make that the focus of your visit and show that it's important to you because it is important to your health. If you have a vascular surgeon in mind that you really want to see, then let me know. And I'm happy to put in that referral at any point, or I have lots of suggestions available.
Yeah. And it's like the fact that you have these brilliant, brilliant doctors like Dr. Brotman, who's a surgeon who you've dedicated your life for veins. Like how amazing, that we have these brilliant minds, and a primary care like, like Dr. Meka, who you are like, let's go over everything and see, where you have to go. So
Mm-hmm.
a recording of this session is going to be emailed to you in the next week, which is amazing. So you'll be able to go through it. To book an appointment with Dr. Meka at Virtual Women's Primary Care, you can call 856-347-3203. And again, all this information is going to be sent in your email. But if you want to screenshot it or write it down right now, this is the information. To schedule an appointment with Dr. Brotman at Rowan Medicine Vascular Surgery, an affiliate of Virtua Medical Group, you can call 856-566-2710. Thank you so much for joining us, Dr. Meka, Dr. Brotman. Another terrific Real Talk. I can't thank you enough. It's one of these things that it's such an intricate information, right? And people don't know who to ask or what to ask. And you're able to take your brilliant minds and break it down and just explain it for everybody. And I just think when we leave these sessions, we learn so much. So thank you, thank you, thank you.